Gestational Diabetes by Danielle Wadsworth. Epidemiology. Gestational diabetes is a type of metabolic disorder resulting from an imbalance between insulin need and availability. GDM is any severity of glucose intolerance that first occurs while a woman is pregnant. It is thought that the development of GDM may represent the early stages of a progression to type 2 diabetes. Three things occur in a woman with gestational diabetes, which is thought to cause a progressive downward slide in glucose tolerance. They are a marked amount of peripheral insulin resistance, decreased number of insulin receptors, and a decrease in the amount of insulin that actually binds to target cells. Morbidity and mortality. There's actually no evidence showing an increase in the perinatal mortality in women who are treated for gestational diabetes. There is, however, evidence that has shown an increase if it is left untreated. If the disease goes untreated, it can carry grave risk for both mother and fetus. Macrosomia is the most common consequence of uncontrolled glucose levels. It puts an infant at an increased risk for having health-related issues, which can be compounded by a difficult delivery or birth trauma. Other poor neonatal outcomes include premature labor, stillbirth, hypoglycemia, erythrocytosis, hyperbilirubinemia, respiratory distress, metabolic complications, and shoulder dystocia. Studies suggest infants born to mothers who develop gestational diabetes may be at risk for childhood obesity and development of type 2 diabetes. Cost. On average, in 2015, the cost of a pregnancy with gestational diabetes was over $6,677. The cost was 95% higher than a pregnancy without GDM due to additional expenses during both pregnancy and delivery. The number of pregnancies affected by GDM was estimated to be over 2.9 million. Therefore, an annual economic burden for GDM was estimated to be over $19 billion. Pathogenesis. Insulin is typically secreted by beta cells within the pancreas in order to enhance cellular uptake of glucose into the cell. When insulin action is decreased, such as with resistance, its physiological function becomes reversed. In the later trimesters of pregnancy, continuous increases of hormones from the placenta decrease maternal insulin sensitivity, stimulating the mother's cell to use a different source of fuel other than glucose. This increases the supply for the fetus. Pathogenesis continued. Insulin resistance initially stimulates the pancreas to increase the production and secretion of insulin as beta cells attempt to maintain normal glucose levels. Over time, however, the increase in demand exhausts the beta cells and they begin to fail, resulting in an elevated postprandial glucose level and gestational diabetes. Clinical manifestations. Most women who develop gestational diabetes are asymptomatic. Those who do develop symptoms usually experience polydipsia, polyuria, and polyphagia. All three may go unnoticed or be contributed to normal pregnancy changes. Clinical manifestations continue. The symptoms of gestational diabetes are directly related to excess or lack of sugar in the bloodstream, otherwise known as hyperglycemia or hypoglycemia. When glucose levels are elevated in the mother's blood, the amount of glucose filtered by the kidneys exceeds the amount that can be absorbed by the renal tubules. As a result, there's a loss of water, causing an excess of urination and an increase in thirst sensation. Weight loss may occur secondary to the excess diuresis or the lack of insulin forcing the body to use fat stores. Other symptomology that may accompany hyperglycemia if levels become too high include blurred vision, fatigue, poor wound healing, and yeast infections. Implications for nurse midwifery practice. There are a variety of possibilities for midwifery management of women with GDM. Some midwives develop parameters to independently manage the pregnancy as long as glucose levels remain within normal limits with dietary therapy. Others consult with a physician on the diagnosis and treatment during the pregnancy. When insulin is required, it is still possible for a midwife to continue to manage the normal aspects of prenatal and interpartum care. However, it would be necessary for an obstetrician or family physician to manage the patient's insulin therapy and other decisions related to fetal surveillance. Implications for nurse midwifery practice continued. All women should be assessed for their risk of diabetes at their first prenatal visit. Women at high risk for developing gestational diabetes should be screened using the 1-hour glucose challenge test in the first trimester, and then again at 24 to 28 weeks if they pass the first test. Women with GDM must be monitored carefully and provided with education and support to promote optimum blood sugar control in order to prevent complications. More frequent prenatal visits to monitor both mom and baby are necessary. Induction of labor between 38 and 40 weeks may also be necessary depending on the glycemic control of the mother.